point here, please. Attendance is taken by the registration, joining through the iEcho platform. So please join the session from the platform, the iEcho platform, and the certificate will only be issued the one who joined through the platform iEcho and complete the feedback survey at the end of session. So please try to complete the survey at the end of the session to guarantee the certificate. Okay, thank you all. Now back to Dr. Amna. We'll continue the cases.
Just I want to welcome Prof. Aida Hussein, Associated Professor at Milan University, a breast surgeon. Welcome, Dr. Aida. Dr. Rabag, the mic is yours.
Welcome. Welcome.
You are welcome, Dr. Aida, and you are welcome all. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين سيدنا وحبيبنا ونبينا محمد. Hello, ladies and gentlemen. Good evening. I hope you all are free from breast cancer and in good health. Today, we are going to discuss why breast cancer is overlooked in breast imaging and how we can make it manageable. Pink to October. We are going to start by the gold standard modality, which is mammography. Can you imagine these two images? This is a DCIS, while this one is artifact. Standard mammography is one of the most difficult radiographic exams to interpret, said David J. Getty, a scientist at Technologies of Cambridge. As mass 3D lesions to be seen in two-dimensional image of the breast, and subtle lesions may be masked by underlying or overlying normal tissue. Normal tissue scattered at different depths can align to mimic a lesion. So what are the peers of mammography is that it is a gold standard of reference for early detection of breast cancer that can reduce mortality from breast cancer by up to 40 to 50%. The purpose of screening mammography is simply to detect a potential cancer. It also has a role in the diagnosis on the basis has a role in the diagnosis of breast cancer, but the radiologist should not try to make a diagnosis on the basis of screening findings alone. Mammography has pitfalls as the tissue superimposition or the high density or artifact or combination of all can lead to mask effect and affect cancer detection, result in a false negative and reduce the study sensitivity. And it is known that screening mammogram miss about 20% of breast cancer at time of screening. And in the other hand, normal tissue scattered at different depths can allow to mimic a lesion and affect the diagnosis by false result, resulting in decreasing specificity of the study. The false negative is the result occurs when mammogram appear normal, even though cancer is present, and this false negative definitely will lead to delay in treatment and false sense of security for the affected woman. Falling into mistakes is a human nature. And there is an ancient talk by Alexander Pope said that to err is human, to forgive divine. However, أهم كلام هو كلام نبينا محمد صلى الله عليه وسلم وقوله كل ابن آدم خطاء وخير الخطائين التوابون. Our objectives for this session is to discuss some factors that affect the detection of breast cancer, review common factors leading to errors in the assessment and management, and improve awareness about the imaging characteristic of variety of subtle malignancies, exemplify some of these common pitfalls, and to suggest some strategies to manage these errors. The path of failure is either failure to detect lesions at all, perceptual error, or failure to characterize lesions correctly as a cognitive error. The other error is failure to manage a lesion, but at the end, all can lead to miss the opportunity to diagnose breast cancer. And the major causes of false negative as either due to technical factors, lesion factor, patient factors, or observer or reader factors. And the technical factors either due to age of the film, poor breast positioning, inadequate tissue compression, or improper exposure. Regarding the patient biological factors, either due to breast composition itself, either it is a high density inherent or acquired due to hormonal therapy, or complex heterogeneous texture with or without high density. Young age group is another factors, and high risk patients can also affect the reading of the imaging. The reader or observer factors is either a perceptual error or a clean misinterpretation. Error can be affected by suboptimal viewing, outside distractions, lack of systemic approach or lesion on a single view, lack of knowledge, non-belief, and biased satisfaction of search. So the major lesion factors either related to a lesion localization, and you know the forbidden or tabar zone locations, and the lesion characteristic itself. And there are a lot of factors or causes under the umbrella of lesion characterization. We'll go through example of some of these. Starting by the technical factors. Here we can see this is our patient. This is the first mammogram performed. We could not see the posterior of the breast. When we repeated, there was a cancer seen in the posterior breast. So this is the poor positioning, and the take-home points is we have to stick to a proper positioning and optimal breast image. Here, this another example of technical fault demonstrate that a cancer seen in MLO could not be appreciated, either part of which could not be seen in the CC view, indicative that the CC is inadequate. So we have to refer to the posterior nipple line to evaluate the CC view in relation to the MLO. And there is also here, this the cancer associated with metastatic adenopathy was eliminated from the field of view, not seen in this image. So never accept improper mammogram. Never accept improper mammography. The edge of the film is also one of the perceptual and cognitive errors on mammogram. And if you have seen any subtle or part of obesity, we have to work on it. Don't ignore it, work on it, and try to pull it in the field of view. If you fail, go and do ultrasound, as in this our case. Here demonstrate a cancer in the posterior medial breast. Another issue is the machine itself. Here we have comparative images, the same patient, same MLO, in a digital versus analog or conventional machines. Can you see how the lesion, this is the small cancer, well detected in the digital machines, even on retrospect, is very difficult to appreciate it in the analog. So, and this is a small cancer seen on ultrasound. So position for mammography can have a greater effect on mammography than it has on other imaging examination. Next example for patient factors. This is an inherent high density mammogram demonstrate very subtle suspicious findings in the medial inferior right breast, subtle architectural distortion and segmental polymorphic calcification, difficult to be visualized here, but you can appreciate it in this spot magnification view. So we have to proceed for spot magnification view. In such, we have subtle finding to make it more clarified to be assessed. And here you can see this is the same image-free neoadjuvant treatment, how it is improved after after neoadjuvant therapy. Another example of inherent high breast density. Here, this patient presented with palpable abnormality in the right breast. It is really difficult to appreciate the mass, but only the adjacent subtle architectural distortion here and the presence of this asymmetric lymph node make it suspicious. And even here in the CC view is really difficult, but that is the mass with subtle surrounding distortion. So this is inherent high density resulting cognitive error and a camouflage effect. Okay, so we have to proceed for adjunctive tool like tomosynthesis or ultrasound. And can you see the lesion here in ultrasound? You see, this is with that linear probe, and here with the convex probe, even we could well characterize the lesion. We could see the whole lesions. We could measure it and characterize it well. So this is to emphasize the use of adjunctive ultrasound for further clarification and characterization. This is also our patient having huge edematous right breast. That could not be tolerate compression, and mammography could not be performed for the right side. However, her mammography on the left side demonstrate extremely high breast density. Okay, but otherwise there is no detectable abnormality in this. We proceed, and even ultrasound was negative. When we performed MRI for staging because of dense breast, we could definitely, here you can see the fungating tumors enlarging the right breast, okay, extending throughout the breast with a necrotic area that does not spare the left breast. And here we can see this segmental clump enhancement, also representative DCIS with invasive component. So MRI is more sensitive than mammography in detection of non-calcified DCIS and its invasive component. This is a single view findings. One of the important cognitive error, okay, and challenging of the radiologist to have such findings. This is a young lady, 30-year-old, underwent a diagnostic mammogram. She has a palpable abnormality. What we could see only an asymmetry seen in the CC view, but could not be visualized in the other view. So we have to work on it. We should not ignore it. And we have to look for any, in the background of dense breast, look for any more denser area, okay? And try to work on it to clarify it, okay? And in this case, you have seen here The suspicious mass proven to be on ultrasound, proven to be invasive ductal carcinoma. This is also our patient having extremely coarse, complex parenchyma. Okay, the parenchyma is coarse and complex. There is a suspicious findings in the left axilla. We don't know if it is a metastatic lymph node or if it is metastatic lymph node or it is just a primary cancer in the left. But here, when we use the electronic magnifying glass, we could appreciate calcification in the left breast. Okay. And in this case, again, a complex without significant increased density. Okay, the parenchyma is really a complex one, and the patient have a palpable abnormality in the right breast. Okay, here in the upper outer quadrant, very subtle distortion could be appreciated, but we couldn't see any masses in this area. So then we have to proceed for either ultrasound or tomosynthesis. That is the sign. Can you see the lesion in ultrasound here? How it is clear, highly suspicious mass proven to be one by one invasive ductal carcinoma. This is the same patient, and this is the tomosynthesis. Can you correlate this? Can you see it? Even on retrospect, it is very difficult to be appreciated in the 2D mammogram. So the tomosynthesis really improve visualization of distortion and delineate underlying masses much better than the 2D, and even delineate the size more properly than 2D mammography. This is our patient also having palpable abnormality having a pain in the right breast. And what in the MLO here, I can see subtle area of distortion due to just inherent background parenchymal density. But on the CC view, I could appreciate here a speculated mass. Here, this is a zoom view, even associated with a calcification. But can you see ultrasound not only characterize that mass as the typical malignant one, but also delineate its extent within the breast, that there are numerous satellite nodules as well as ductal extension down to the nipple, representing a multifocal disease. You can well see it here in this chest CT was performed to systemic staging. If you follow, you can see how the lesions and the adjacent satellite nodule and the enlargement are enhancing ipsilateral nipple. So look for other smaller lesion when an elephant abnormality is seen, like this daughter of an elephant, satellite representing satellite nodule. Look for any other suspicious features. Okay. This patient presented to us with a mammogram from screening mammography from outside, demonstrate that she has right breast abnormality. If I ask you, can you see anything in the left breast? It is really very subtle, very subtle. Subtle abnormality in background of high density result in a perceptual errors, okay? And here there is an asymmetry in the medial inferior breast and proven to be a contralateral cancer. And this is 25-year-old lady with a palpable abnormality, okay? Can you see it here? It looks like just a fibroadenoma. It has a benign morphology, but can you see it on ultrasound here? It is non-parallel with a deeply hypoechoic with a rind proven to be invasive cancer. So Age does not exclude malignancy, 25-year-old. Okay, and familial cancer usually associated with young age and associated with benign morphology. So benign morphology or mammography or in breast imaging as a whole does not always imply benignity. And we have to proceed, or we have to companion the mammography with ultrasound, okay, to further characterize the lesion. So let us go for lesion factors. This case presented just with left breast edema. Okay, we don't know if this edema is due to systemic cause or due to underlying breast malignancy. Ultrasound doesn't add much, demonstrates subtle, non-specific findings, diffuse, scattered, altered echogenicity or non-mass-like lesions. But when we proceed for MRI, demonstrate that it is an inflammatory carcinoma with multiple multi-regional clump areas of non-mass-like enhancement in edematous breast, enhancing skin nodules with skin thickening. So MRI depiction of a primary breast parenchymal lesion in inflammatory breast carcinoma seen in 98% compared to 65% of mammography. And again, this is architectural distortion in a patient presented with pain. Ultrasound was not specific. MRI demonstrates a clump segmental enhancement with adjacent skin involvement here and patchy similar changes in the contralateral. It was a DCIS with invasive component in the left breast, and 3 years later ended also with left mastectomy for the same disease. So the architectural distortion has a positive predictive value for breast cancer up to 60%, and usually is a subtle findings. So we have to be careful so as not to miss a cancer presenting as an architectural distortion, especially if it is associated, if it has a similar density, isodense to the adjacent parenchyma, unlike the mass that can be well appreciated, and especially the fat interspersed within this architectural distortion that you might imagine that this is part of the parenchyma. Here we can see the area of architectural distortion and corresponding MRI. In such cases, we have to proceed for ultrasound, and if it doesn't solve the problem, proceed even for MRI. This case from literature, invasive lobular carcinoma, seen as a speculated lesion with fat seen within. Okay. Previously, we know that, okay, there was a thought that any fat present within a lesions, okay, implies that lesion is a benign one. But the presence of tomosynthesis and more detailed structures and detailed characteristic features of the lesion, we nowadays a lot of intra-lesion fat could be depicted. So presence of fat does not preclude biopsy if the lesion morphology is suspicious. Another invasive lobular carcinoma presented as shrinkage breast. And here we emphasize the correlation with earlier mammogram. This is the 3 years earlier. If you look here, this is the recent one. The right breast is smaller compared to the left one. You might be in a dilemma. Which one is abnormal, the enlarged or the smaller one? Okay, and the findings are really subtle. But when we compare it with the previous one, definitely it is obviously the disease one is the right. Also, we can look for the interface, fat, glandular interface, and the space, anterior and posterior, looking for the fat, because the parenchyma shrinkage, you will see more fat behind the glandular tissue, okay, mostly seen posteriorly, but also can be seen underneath the skin. So proceed for ultrasound. Here it demonstrates a shadowing mass, but sometimes even on ultrasound, difficult to evaluate lobular carcinoma, and the most sensitive modality is MRI. Another lobular carcinoma just presented as a microcalcifications. Okay, just a group of polymorphic microcalcifications and negative ultrasound findings. So excisional biopsy revealed classic invasive lobular carcinoma. So as you know, invasive lobular carcinoma clinically imaging, especially mammography and ultrasound, is the challenging area. And this is a 32-year-old lady presenting with pain. Here we can see an oval mass at the posterior breast appear as if it is having a benign morphology. But the use of spot magnification view, it can characterize the margin as even speculated. So we have to emphasize the role of spot magnification view in evaluation and characterization of such lesions. Suspicious but subtle findings. Again, if you look for this lesion here on mammography, it seemed to be just an oval isodense mass with subtle adjacent asymmetric extending to the skin. With this is the only subtle findings make it suspicious. This skin tag and the adjacent areolar skin thickening. But can you see it in ultrasound how it characterizes the lesions? Okay, characterizes the lesions, and not only frankly malignant feature, but also demonstrate the extent with ductal extension and branching pattern. Another benign morphology. As you know, there are certain subtypes of breast cancer presenting with benign morphology, some of which is mucinous cancer, as in our case here, and also which can make it difficult that the patient has bilateral multiple masses. But this one in the left periareolar region is really dense. So we have to do spot compression magnification view to characterize the margins. And when you see here, the margin microlobulated and subtle perilesion reaction and extension into the nipple areolar, the same findings, ultrasound, and then biopsy-proven mucinous cancer. And here, this is a 50-year-old lady, her screening mammogram. There is single view asymmetry, okay, not appreciated on MLO. And then the second round demonstrate increase in this asymmetry with even still a single view, but slightly here there is a relative increase density. So a single view asymmetry usually a dilemma, but here the indirect signs or subtle features is the areolar skin thickening, and this proven to be overlooked breast cancer. So what is the doubling time of breast cancer? It is known that the single view, on retrospective study, one of the causes of missing cancer in a lot of cases or many cases, okay? And a gradually developing asymmetry represents 16% of the cancer. And the doubling time range from 44 days to 1,800 days with the mean of 212 days. Another area of challenge is scar carcinoma, okay? the scar carcinoma, as seen here, okay, and how we can manage this and to avoid this perceptual and cognitive errors is to correlate with the previous. Otherwise, it will be really difficult to differentiate if these are post-therapy changes or there is evolving cancer. And if we look here, definitely the arrow from this image to this one, that means this is the earliest mammogram and this is the current one. It demonstrates edematous changes. So these are new, signify that this is scar carcinoma. So correlation, we emphasize that the correlation with the baseline pre-therapy or post-therapy even, previous mammography is crucial. Otherwise, if you haven't, you have to proceed for characterization with MRI. This lady presented to our department for screening mammography. It is almost 80-year-old and demonstrate two small nodules in the upper outer and upper central right breast, presumed to be intramammary lymph node. Proceed for tomosynthesis. The upper outer nodule proved to have typical intramammary lymph node. But can you see the outer central lesion on tomosynthesis better characterized and seen as an speculated mass? This is evolving cancer. Here you can see this is a typical, the 2D, the two nodule, okay? And this one is the typical intramammary lymph node, but the other one is evolving cancer. Can you see it here in the zoom view? Speculated mass. So tomosynthesis is really helpful to eliminate these perceptual and cognitive errors. This is specifically, it was recognized or cognitive error. Okay, another patient of in our experience, okay, presenting with typical right intramammary lymph node, but another smaller nodule in the same location in the contralateral breast. But in spite of this nodule is smaller than this one, it is denser. So that is the clue. It is denser, and there is no associated fatty hilum to say this is typical intramammary lymph node. Ultrasound was negative. So we have to proceed for MRI or tomosynthesis for further characterization. Let us go to the reader or observer factors, and this was my first missing in my practice of breast imaging due to cognitive or recognized errors. The patient obviously have had left breast cancer with axillary metastatic adenopathy. But this one, it seemed to be an oval lesions. And I couldn't recognize this subtle perilesion, edema, and architectural distortion. And I suggested that this lymph node probably reactive due to the cancer patients, okay? So we should not characterize a lesion as a potential benign based on a single features. Can you see here the zoom? Okay, this is on retrospect. On a zoom here, even the margin appear indistinct. And the ultrasound was cystic, but the morphology was not typical of simple cyst. It is not circumscribed, and it has an irregular shape. So this is post-treatment, both affected and regress, even this morphologically appearing cancer. Another cancer missed by one of the radiologists, presenting as subtle architectural distortion adjacent to this fibroadenoma. The patient having bilateral fibroadenoma and presence of benign lesion distracting the radiologist from a subtle underlying malignancy. And here you can see the distortion even in the follow-up, even pulling the nipple. And here in the spot magnification view, this is the area of distortion affecting the adjacent fibroadenoma, a case of concurrent and collocated invasive carcinoma and fibroadenoma seen in up to 5%. Another case of invasive cancer arising or presenting as presenting with benign calcifications, which is a popcorn calcification. Can you see this lesion? This is a popcorn calcification, but the lesion here is not very clear, but it appears to have, the margin is not very circumscribed. And here you can see it on ultrasound, and typical popcorn calcification and considered to be benign, but the morphology is not benign. But the radiologist can be distracted by these typical benign features to ignore the other not very clear morphological suspicious features. We have seen this one. Okay, so again here there is a perception error due to apparent benign morphology. It is apparent. Yes?
I think the time is over.
They told me they will, okay, about to finish at the end. Okay? This region here is a high density, okay? And in spot magnification view, it is obviously an irregular with non-circumscribed margin. And in this case here, cancer can be missed by, because it is also subtle findings. There is asymmetry with calcifications. And this one is important because it is interval cancer, okay? This interval cancer, this is the here they ignore this area of focal asymmetry, and the patient before the second round present with a palpable abnormality, and the mammogram demonstrate a suspicious mass proven to be cancer. And here you can see the cancer on ultrasound, and the cancer ultrasound, it was unifocal, but on CT demonstrate that the lesion extending and involving the chest wall. So in 6 months interval, the patient became locally invasive cancer, and we have to look for other lesions in the remain of the breast when we see in an index suspicious mass. We should not, we should avoid satisfaction of search and exclude multifocal and multicentric, okay? And we are always aiming to beat cancer as small as possible. And here is the conclusion. Our conclusion is that negligence, missing is not usually due to radiologist negligence, okay? But we have to be aware about the measurements to avoid this negligence, and to be aware about certain types and presentation if presented as morphological benign cancer and slowly growing cancer. And at the end, we have to judge a lesion by its most suspicious features. And if dealing with index cancer, we have to search for additional one. And we should not forget our strategy of breast imaging, lesion imaging management, starting by mammography, then sonography, then MRI, and always we have to consider the clinical. Thank you very much.
Thank you very much, Dr. Rabah, for this valuable presentation. We will have some time for questions. If you guys have any questions for Dr. Rabah, we want this to be as interactive as possible, so we gain the best out of it. So anyone has a question, please raise your hand, and then you can unmute your mic. Any questions? Okay, are you sure? No questions?
Can you check the chat for any question?
I can't see any questions here. Okay, so we will move to the next presentation. It will be with Dr. Rabab as well. I know all of you know Dr. Rabab, of course, but for those who don't know Dr. Rabab is consultant radiologist. She's the head of women imaging in Soba University Hospital, and she's the main organizer of these symposium and October events. We do this annually. Every year we do have an event. And before the war, of course, it used to be face-to-face presentations, face-to-face symposium, and many workshops, many free clinics. It actually used to be amazing. So we really hope Sudan will come back and we will have this symposium next time on a face-to-face presentation. We will be able to resume our work as we used to. So thank you very much for this presentation, Dr. Rabab. The next presentation will be with Dr. Rabab. It will be about the pros and cons of breast ultrasound. So welcome again, Dr. Rabab.
Thank you, Ila, for this nice introduction. Okay, let us go for...
Ilaf, there is a question in the chat.
Yeah, I just
Okay.
saw.
Okay, no problem.
Can we differentiate benign and malignant cancer deposition just from imaging?
What?
Can we differentiate the benign and the malignant cancer deposition just from imaging? This is from Shadin Ahmed.
How? Again, sorry, I couldn't recognize what you are saying.
She's saying, can we differentiate benign and malignant CA deposition just from imaging?
Before position, before the word before position.
Assalamu alaikum.
Alaikum salam.
It's better to be.
My question is, Assalamu alaikum, ya Dictora.
Wa alaikum salam. You are welcome. You are very welcome.
Thank you. My question is that about the calcium deposition. Yes. It may be benign and may be malignant.
Yes.
So could we differentiate it just by the imaging?
Yes. Yes, definitely yes. You see, we have certain, there are about 9 types of typical malignant calcification, breast calcifications. Okay. And otherwise, there are also 4 types of suspicious calcification on mammography. Okay. So by characterizing the calcifications, we could differentiate between a benign, typically benign, and a suspicious type of calcification. But regarding the suspicious type, is not 100% implies associated with cancer. This even suspicious morphology can associated with sometimes some types of benign diseases. But since are associated with cancer, we have to raise the level of suspicions according to the type of calcification and the associated findings. If an isolated calcifications, for example, a pleomorphic calcification, then it will be by RAD4B. Okay, but if it is linear branching pattern, okay, or linear pattern or linear branching pattern, without any associated feature, it will be a by RAD4C. Okay. Are you satisfied?
Yes. Okay. Thank you.
No thanks. You are welcome. No thanks for my duty. If you have no more question, we can proceed. Okay.
Yeah, no more questions. Proceed, please, Dr. Bob.
Okay. The second session is about the pros and cons for breast ultrasound and why breast cancer missed and how can be managed. Again, October is breast cancer awareness, and we have to see pink everywhere. Ultrasound is the second chair in the orchestra of breast imaging, and it's really helpful as adjunct to mammography, especially in a dense breast for cancer detection, and can detect a missed cancer at mammography in up to 27%, and can also have a major role in the diagnosis of breast cancer, especially for can detect and characterize palpable abnormality not seen on a dense mammogram as in this case, and characterize global asymmetry as atypical malignant mass. In this example, we have seen this before, how it characterized. And in this example here, we can see multiple masses, mass here and here and here on mammography. The three masses on mammography appear as a water density, but this one, ultrasound demonstrated as a simple cyst, while this mass seen as a complex cyst, and the third one, it is a soft tissue mass. And it can evaluate the disease extent. Here, this is a malignant mass and ductal extension. You can see it here on this CT, definitely performed for staging. And here we can see this is a focal asymmetry. Okay, it characterizes it as a highly suggestive malignant mass, okay, with hard elastography and the ductal extension down to the nipple, multiple satellite nodules in a multifocal disease. And this example, ultrasound definitely, obviously, demonstrate the residual disease in a patient receiving chemotherapy treatment and evaluate the response much better than this mammography as the patient both bilateral edematous due to systemic cause. And regarding this case here, we can see an oval mass in the inferior axilla seen as a suspicious lymph node, you see in the left side, as well as this area here representing a malignant mass. And can you see, but not only that, detect contralateral malignancy with ipsilateral axillary lymph node. These are not cysts, these are necrotic lymph nodes. And ultrasound definitely is the best modality to evaluate axillary lymph nodes. Can you see this non-specific lymph node on mammography? Ultrasound demonstrates this deposit focal cortical thickening due to underlying deposits, and type 6 lymph node here in the interpectoral region, the Rotar's node with the peripheral vascularity. So our objectives today is exemplify some of the pitfalls and just some ways to avoid them on ultrasound. It's the same measure for groups affecting all the modalities, technical, patients, lesion factors, and the reader or observer. And the technical factors regarding ultrasound is limitation of handheld ultrasound machines, inadequate spatial resolutions, small 5-centimeter field of view, and coarse, noisy image, poor, inconsistent technique, and inadequate position, poor, inconsistent technique, and so forth. And regarding the reader or observer causes, interpretation error, the same, either perceptual or clean misinterpretation or cognitive. And here there are many factors affecting these two main reasons or main causes. And regarding the patient factors, again, the young age, high risk group, the parenchymal textures of the breast, starting by the technical factors. This, my patients, Can you see the labeling here? It is just below the clavicle. This is the cancer detected just below the clavicles, okay? And these two, this is two, look here, near to the midline. There is no surrounding parenchyma. It's so medial. And this is at the mid-axillary line. So consider the locations as technical challenge. And this is at the axillary tail and the lower axilla. And this is lateral axilla, okay, extreme lateral toward the mid-axillary line. So the teaching point here is while examining the patient, we have to extend our examination from above to the clavicle down to the inframammary fold, and laterally from the axillary, mid-axillary line to the midline. And while scanning toward the axilla, don't raise the probe. Continue your examinations while scanning, okay? Don't raise, otherwise you might miss a lesion in between at the apex of the breast, at the axillary tail, and the lower axilla, okay? And in the medial aspect, continue even my technique. While I'm scanning, I continue from one breast to the other without raising the probe, okay? This is a non-palpable isocoic cancer in the retromammary zone. Can you see it is isocoic to the adjacent fat? This is one reason can result in perceptual error, perceptual as well as recognizing error, okay? That is the lesions. And here, while adjusting, so we could appreciate and measure it. And again, this is a palpable abnormality, isocoic lesions. And here could not visualize it, but you have to put your finger, look and ask the patient to put her fingers and make sure that and clarify what is going on at the site of palpable abnormality. And again, we have to sweep around any lesions. We should not just put our probe like this and see the lesion from one angle. Otherwise, we could miss a cancer. In this example, from the first glance, it looks like a fibroadenoma. But when we sweep around, look for the margins are suspicious in a high-grade breast cancer. Another high-grade breast cancer can be like this. But when we sweep, we could see that this ductal extension, okay? The ductal extension is part of the cancer. If we measure this only and we did not mention there is ductal extension, the patient, the surgeon is going to remove, if there is no indication, other indication for mastectomy, they are going just to remove this mass, and the patient might present with non-free margins. And this also, a mass here appear like a cyst, but because of improper setting, when they adjust the gain, it was just a soft tissue mass, and due to high-grade cancer appear like a cyst. And in this case here, okay, the superficial lesion, usually we need to use a higher frequency probe, otherwise can be missed, especially if it is isoechoic to the surrounding fat. And sometimes we need to use the convex probe to evaluate for the axilla when it is deep, or if we have a huge breast, otherwise we can miss a lot of lesions. Regarding the patient factors, here we can see the patient having a fatty breast, and the lesion is a small, okay, this small cancer, okay, isoechoic to the surrounding fat. So this can result in recognition, in perceptual and even recognition errors. So background parenchyma, when it is fatty, can result in a challenging to pick up small cancer, especially if it is isocoic. Can you compare it with this very sensitive fibroglandular white parenchyma contrasted the hypoechoic cancer on it? Another things, the same, here we have a morphology benign, apparently morphological benign lesions. It is isocoic to the surrounding fat with very subtle suspicious feature, which is echogenic ringed. You see, this is echogenic ringed. And very subtle here, cutting the adjacent tissue. This is an 18-year-old presented with a bulbable abnormality. If you look here and considering her age, you will rush directly to say this is a fibroadenoma. But when they scan again and look, sweep through the margin, definitely this is microlobulated, angulated, and even some speculation here. And this is starting to have a duct extension, and it was proven to be invasive cancer. Can you compare it with this pseudocapsule completely surrounding a fibroadenoma? And even the fibroadenoma here is more homogeneous and gently hypoechoic, unlike this one, some heterogeneity and deeply hypoechoic compared to the benign. So this is a patient and lesion factors. Again, patient and lesion factors. It is only 26-year-old African woman with genetic mutations, see, presenting with this mammographically and even ultrasound benign appearing masses. So it was biopsy confirmed high malignant phyllodes tumor. So such patients with familial cancers are usually young, and they have a benign, presented with a benign morphology, misdiagnosed as a fibroadenoma. Another young lady, 25-year-old, this case also from literature, okay? If you look for the lesion, you can say this is a fibroadenoma, but it is not. It was a triple negative breast cancer, see, in a young lady. Okay, going to the lesion factors. This is morphologically appearing lesions, okay? Multiple morphologically, this is 35-year-old, and this is 33, the two. Only this one is 55. But what about, it looks like morphology, the regular shape, and apparently circumscribed masses. So benign morphology, proven to be triple negative cancer. So high-grade cancers usually present with a benign morphology. There is no time to induce surrounding desmoplastic reaction that result in the characters of the slow-growing cancer. So the predictive descriptors of malignancy, again, in this case, is the rounded. Rounded is not a reassuring morphology. Yes, oval, yes, but rounded is not a reassuring, which is considered to be a non-parallel. And if we look even, this is not, sorry for the arrow displays, this is not a pseudocapsule. It is a relatively thick. So this represent an echogenic ring. And if we look carefully here, we can see what there is area of cutting. So there is architectural distortion, and this was triple negative invasive carcinoma grade 3 and the others. This is my patient I have shown on mammography that it is not a typical simple cyst. And what I can say after that, margin is the key, margin is the key, margin is the key, okay? And after that, I became more cautious and looking for any associated features. This from the literature, though the margins are circumscribed, but there is significant surrounding hyper-echogenic reaction signifies that it is a high-grade tumor rather than just a simple cyst. And this is my patient's segmental ductectasia with calcification. Any intraductal lesions, calcifications, okay, is suspicious. So it doesn't look like very impressive of malignancy on ultrasound, but when we correlate with mammography, it demonstrates that it was segmental pleomorphic calcification. Then we proceed for ductography, demonstrate that corresponding arborizations, ductal dilatation with irregular beaded appearance of the ductal arborization and filling defects, and the corresponding MRI demonstrate clump ductal segmental non-enhancement proven to be high-grade extensive DCIS. So we have to correlate with other imaging tool. This is my patients. When I have seen the cyst irregular, definitely mammography is not going to add much if there is no associated calcifications or other suspicious features, if it is only cyst. So since the cyst is irregular, I proceed for MRI, and this irregularity was due to the just adjacent parenchymal reaction in persistic inflammations. It solves the problem. Another MRI solved problem for our patient. It appeared here on ultrasound like a cyst with a mural nodule, which is suspicious, not specific on mammography. MRI here demonstrate bilateral fibrocystic, and this is the cyst, demonstrate fluid level, and post contrast demonstrate, this is the magnifying view, demonstrate just minimally inflamed or complicated cyst. Can you correlate it with this? Our patients also, but the cyst here have a mural thickening, mural nodule and mural thickening proven to be a cancer. So a complicated cyst is usually a challenging area of misinterpretation or cognitive errors. This is not a cluster cyst. This is a high-grade cancer. Doppler helps us. Thank you for Doppler, but not always useful. If it is negative, it doesn't exclude. But look how this cyst proven to be just a soft tissue rather than a cyst in a high-grade cancer. And these are not cysts in the axilla. If you have seen even one single isolated cyst in the axilla, don't rush and report it as a cyst due to ectopic breast in the axilla or fibrocystic. We have to be cautious. There are a lot of missing necrotic lymph nodes, metastatic lymph nodes in the axilla, misinterpreted as cyst. And the non-mass-like enhancement, especially when it is isochoic or slightly or gently hypochoic. It will be difficult to be interpreted and can be just result in perceptual or cognitive errors. But if we have seen such type of lesion, we have to go and use the harmonics. It's really helpful technique and make it more pronounced if it is real. If it is not real, it will disappear on harmonic. If it becomes more pronounced, that means it is a real lesions. Also, we can use elastography, as in this non-mass-like enhancement, non-mass-like lesion, hypochoic focal area, okay? Elastography demonstrates an irregular mass, delineate the border of the lesion, and demonstrate that it is hard and more suspicious. So it's recommended to use advanced ultrasound technique like Doppler, harmonics, or elastography. And this is our patient you have seen on mammography with the coarse calcification or core calcification, but really has an irregular shape and indistinct borders. Can you compare it with very typical fibroadenoma, okay, hyalinized fibroadenoma with popcorn calcification? Yeah. If we have seen a popcorn calcification or any typical calcification in association with the mass, we have to characterize the mass by morphology first. These are additional features, not our main feature. The main feature is always morphology. Morphology number one, and margin is a key. This is our patients. Can you see it how it is clear on CT here? But because it is isochoic and the surrounding fatty parenchyma, it was really difficult. But if you concentrate, the mass has a non-circumscribed margin. And not only that, here you can see the ductal extension. You see that is a lesion with echogenic rind and ductal extension. So again, this type of lesions can be much more clear on harmonic. Not only non-mass-like, but only the mass. If you suspect you have a isochoic mass, use harmonic and it will be clearly visualized. Another area of challenge is the hyperechogenicity. Yes?
You have 5 minutes left.
Yeah?
5 minutes left.
Okay, so this is a hyperechoic lesions, and usually for hyperechoic, look for the central hypoechogenicity. Okay, and this is here malignant phylloides. Here, this lymphoma, can you correlate it with or compare it with this hamartoma? So in such cases, we should not be biased and we should not be overconfident to say this is typically benign. We have to correlate with other modality like mammography and so forth. And this my patient. This is fibroadenoma, but this is invasive cancer. Okay. Regarding the observer, here again, this is my patients. And this from the literature, these are invasive cancer, while this fibroadenoma, again, margins. We have to look for the margins when it is very sharp and there is pseudocapsule, will be reassured. Otherwise, if you look here, posteriorly, this is not very sharp. And in this case here, again, the margins, these margins are not clear, are angulated. And this is not a hyalinized fibroadenoma with posterior shadowing. This is an echogenic rind, and this is affecting even the adjacent skin with some tethering. Use the convex probe to visualize the whole lesions, to characterize it. You can see here you can see the echogenic rind and the speculated non-circumscribed margins. This is, again, this is not a cyst. This is malignant intramammary lymph node. And this is echogenic rind rather than a thin pseudocapsule. You can compare it with this one. And this one here, again, you might say this is a fibroadenoma, but actually this is highly high-grade invasive cancer. And Doppler here can help us. Okay, it has an angular margin only, and where the area of angular margin or infiltration, while the remain is intact capsule. You see, there is chaotic vascularity, signifying new vascularity. Also, this is very small lesion, but because it's cutting the parenchyma or the adjacent tissue, signifies that this is a malignancy, and in such cases, this is my patient. But this from literature, also we can use the for indeterminate lesions, we can use the elastography. And this is my patient. If you look here, you can say this is definitely fibroadenoma. But can you see the posterior? When we sweep, we can see infiltrations and tracking and invasion of both pectoralis major and pectoralis minor muscles. And this is from literature. This is not a fibroadenoma. This is a mucinous carcinoma. And according to Stephanos, we will not be very relaxed and reassured if we have seen the oval blump, okay, like this oval blump. But if it is flattened, oval flat, then will be reassured. If it is oval flat and with pseudocapsule parallel, then the negative predictive value can approach 99.9%. And this case here, the non-mass-like lesions, you see, and usually this is a challenging area with a fibrocystic. While this fibrocystic, these are infiltrating cancers. And this is young lady, okay? The first glance, the lesions look like this. We have to be patient. With difficulty and a lot of search, we could appreciate this irregular mass with intra-mass cystic component and duct and calcifications and the extent of the mass. Even look, there are interrupted ducts, okay? And the nipple areolar complex here relatively thickened. There is some increased vascular echoes in the adjacent area, and there are pathological ipsilateral lymph nodes. This is not intramammary lymph node, but it is a malignant one. It is not, this is not a fibroadenoma, okay? The same lesions here demonstrate abnormal vascularity. This is also my patient, small intramammary lymph node, but it was metastatic lymph node. And this is again intramammary metastatic lymph nodes. This is, you see, the mammogram hyperdense and adjacent asymmetry here in the upper outer quadrant. From the first glance, we can see this like just an intramammary lymph node, okay? But when we angulate, look how it is irregular. And the adjacent, there is adjacent non-mass-like lesions. This is the non-mass-like lesions. A lot of non-mass-like lesion here. And can you see this part of the lesions? Okay, this is an afferent vessels, okay? And even at 6 o'clock, there is a lesion. So we have to be patient and we have to look for other suspicious features. This is axillary, this is axillary evolving abscess, but this one, it was axillary papillary carcinoma. So we have to be careful while evaluating the axillary lesions so as not to miss a cancer in the axilla. And again, one of the area of challenging is the fat necrosis. You see, this is breast carcinoma, while this is a fat necrosis. And this is one of our Sudanese patients again, you see, and the machine is not high quality. We could pick up abnormalities or malignancy in the upper outer, and this one in the lower medial, okay? And even this, the valley between the two breasts in the midline. So satisfaction of search, don't avoid satisfaction of search, okay? Look for other lesions, okay? When you have seen an index cancer, look for additional cancer, okay? So radiology aware of different malignancy having benign features, and cancer may be deeply hypoechoic, simulating simple or complicated cyst, and most suspicious finding determine the final Barrett assessment and need for biopsy. Margins are essentially important. Complex, solid, and cystic masses are fairly uncommon. However, more than a third are malignant. They may be variations in locations of detected lesions clinically, okay? Because the patient's upright and supine, we have to consider that, and cancer can be missed because the lesion occult, even in retrospect, or frankly overlooked, is noted, but considered benign, distracting by benign lesions, having benign feature associated with subtle suspicious findings next to it. So to reduce perceptual and cognitive errors, okay, resulting in cancer missing, it is essential to thoroughly sweep along the margins and adjunct technique like Dopplers and elastography, and those to evaluate the lesions. And we should not forget our breast imaging strategy. And thank you very much.
Thank you, Dr. Rabab Ahmed Al Hassan, the MD radiologist and FRCR holder. It was informative and knowledgeable. Now the time is open for questions. There is a question. It takes a lot of learning and observation to differentiate different types.
What?
Does it takes a lot to learn and observe differentiation between different types of breast cancer?
It depends. It depends. Yes, sometimes the study might take 10 minutes to 15 minutes, okay? Quick, straightforward. But sometimes we might spend 1 hour in a single case, so as not to miss. It depends about parenchymal textures, the clinical of the patients. Is the patient high risk or not a risk patients? A lot of considerations, okay, regarding the case. If she has a palpable abnormality, but we could not explain that palpable abnormality, you might need to take more time looking and clarify what is going on, and so forth.
There is a next question.
Yes, could I ask?
Okay.
Okay. Hello everyone. Thank you for the lecture. Sorry that I have missed a lot of information, but I'm asking regard the breast staging, like level 3 and level 4 breast cancer staging. Okay, is like BRAT 3 and BRAT 4. What's the most initial? Because this is always make me distribute me. What's the best initial investigation I should do for a patient with lump is like above 30 or above 30 years old with lump and no other information I have? Could I do first, despite mammography or ultrasound, when I will do final aspiration, needle aspiration, or I will do cord biopsy, or its regard? Because this question always I have been seen in a lot of exams, so sometimes the answer will be like do fine needle aspiration if you have suspicious, or do cord biopsy if the patient have a family history of breast cancer. Sometimes the question itself it doesn't clear for me, so I cannot choose the right answer.
Okay, we discussed that issue in the lecture few days ago, but I can answer your question now, no problem.
Highly
It depends.
appreciate it.
Yeah, no problem. Okay. So if the lady having a clinical abnormality and seeking radiological advice and radiological imaging, okay, breast imaging.
Okay.
Usually, it depends on her age. We start with either mammography, proceed to ultrasound, or we start with ultrasound, and if indicated, we go back to mammography, and if indicated, we proceed for MRI. Okay, to clarify things. And then, if there is suspicious findings, if there are suspicious findings, okay, then we will recommend biopsy, or it will go directly in some radiology department or booked for biopsy, okay, for core biopsy of the breast. Or if the pathology in the axilla lymph node without any underlying breast biopsy, to biopsy the lymph node, FNA in general. If mammography and ultrasound both were negative, sometimes either you will result in, you have many results. Either both are positive, both are negative, or one positive, the other negative. If both are negative, it depends on the clinical. If it is clinically suspicious and it is palpable, you have to proceed and take biopsy clinically, blindly. Okay?
Okay.
But
Blind.
if it is of low suspicion, clinical low suspicion, there are abnormality, but not very suspicious. Okay? Or the patient is a suspicion, it depends. They are grading, they are going to grade the suspicion regarding the examination, the history and examination. Sometimes if the patient high risk, clinically the lesion is not very suspicious on clinical examination, but she's a high risk. So it is suspicious because she's a high risk. Okay? It depends. If it is high risk, they have to proceed. If it is palpable, proceed and do biopsy based on clinical. If it is not, if it is of low, okay, low suspicion, then consider follow-up, clinical and radiological, because it doesn't exclude
If
cancer.
she is pregnant and she has breast changes, and I will do ultrasound.
Yeah, you have to go for ultrasound. So what is the question here? Yes, you're right. For pregnancy, you are going to start with ultrasound.
السلام عليكم.
وعليكم السلام.
دكتور رباب، مستر عمر فاروق، كيف أحوالكم؟
مرحبا دكتور عمر، شرفتنا، أهلا
الله
بك.
يسلمك. الله يسلمك. Very good session, very informative, and I quite agree إنه المودalities اللي أنت you describe الماموجرافي والالتراساوند are the key for the diagnosis. وأنا اليوم كنت في مؤتمر، ف في تطورات ماشيه شديده في
الايميجينج.
ايوه، في الايميجينج. وانا مشوف في الفيوتشر يعني حتى الماموجرافي هيكون الانهانس ماموجرافي والالتراساوند توكينج زي ما انت قلت هسه في الالكتروجرافي وفي المايكرو بابل انهانس التراساوند يعني بالكونتراست. فديفنتلي يعني هنشوف الشباب ديل هيشوفوا بعد شويه موداليتيز ميك كل الدياجنوز ده ماتش ايزي. لكن الكورنر ستون از يو سي الكورنر ستون لحد هسه انه الواحد اذا عنده ماموجرام وعنده التراساوند ويز دوبلر وكان ماسترينج التكنيك فديفينتلي كان دايجنوز موست اوف كيسز. يعني ايوه الوت. فالخبره والتكنيك is very important as you mentioned في الدسكشن بتاعك. thank you very much for يعني showing a new generation الحاجات دي. and I think in the future you have to introduce them to new technology, emerging new technologies دي على اساس
احنا قدمناها يا دكتور، قدمناها الاسبوع اللي فات.
كويس. very good very good.
النيو تكنولوجي ويحتجوا عليها، قالوا لي اللكشر ادفانس ادفانس. فقلت لهم ادفانس لانه نحن ما عندنا، بس لانه نحن ما عندنا ما لانه معناتها هي ادفانس.
لا اتليست بس يعرفوا بها، لكن زي ما قلت يركزوا على الحاجه الموجوده وهي دي. طبعا الدايجنوزنج هسه كل الكلام ده برضه in addition يعني، لكن الحاجات الموجوده دي هسه دايجنوز 99% of الكيسز يعني.
ايوه.
فديفينتلي
لا لكن even التوموسينسيس it add a lot for detections and characterizations. يعني it reduce the recall, it improve الكانسر detections. يعني شفت الكيس بتاعتنا نحن هسه بتاعت الليمف نود، البريزيوم انترامامري ليمف نود، واحده طلعت ليمف نود والثانيه طلعت كانسر.
ديفينتلي لا هو ديفينتلي لما يكون عندك كل الموداليتيز انت يور الدايجنوز بيكون مور اكيوريت يعني في كل الحاجات. اوكي.
السلام عليكم يا ابن
عليكم
الرباط.
السلام. عليكم
شك...
السلام.
شكرا جزيلا. بفتش من قبل على الحتة ريس هاند في ما لقيتها.
حاولي. You are welcome. عندك
بنشكرك يا رباب، واستمتعنا جدا ب your very يعني systematic والسهل الممتنع يعني presentation.
الله يديك
I
العافية.
like I like very much your presentation, so I enjoy it.
Thank you.
وبنشكر جدا على نشر المعلومات انه radiology is the first step of diagnosis. يعني دايما انا بذكركم بواحد من اور سينيورز ربنا يرحمه، كان بيقول انا اللمب ماسكه بيدي اعمل لها الترا ساوند ولا اعمل لها ماموجرافي ليه. فبنشكرك جدا على انك you have يعني introduced the knowledge وال حكايه الامبورتنس اوف ذا راديولوجي. ويعني برضو حاسه انا بشكرك على انك انت ذكرت الاستاجرافي، لانه it's a new
تكنيك.
يعني تكنيك. في برضو الثيرمال دي ما عارفه ايش ذكرتوها
والله
في
والله يا دكتورة، دكتور من غير مقاطعة، يحتاج إنه الليكشر بتاعت الأوفر فيو دي نعيدها تاني شكله، لأنه الناس
بس
ما
بس
قررتها.
ورونا يا اخوانا.
الناس لانه ذكرناها، ده كله ذكرناه في الاوفر فيو، وحتى الدكتورات احتجوا قالوا لي دي ادفانس. قلت لهم انا بس ذكرت انه في ستاديز زي دي بتتعمل للبريست، انا ما ولا اتكلمت عنها ولا شرحت عليكم ولا وصفتها. انا قلت في حاجات زي دي الان الناس شغالين يعني شغالين وصلوا كده، ونحن لسه يعني ما عندنا
خلاص.
enough.
اذا ريكوردد رسلوا لنا الريكورد، لو ما ريكوردد معلش نكلفك تعملها لنا تاني. دي حاجه.
بعد
الحاجه
اكتوبر ما في
الثانيه
مشكله، نعملها بعد اكتوبر.
خلاص ان شاء الله ان شاء الله.
عارفه
الحاجه
ليه؟ ممكن
الثانيه
اوريك ليه الميزه في شنو،
مم.
في انه نعملها تاني. ليه؟ لانه بيكون في ديسكشن، يعني مش
تمام
عشان مش عشان
تمام
مش عشان لانها هي تكون ريكوردد ما مشكله، لكن ممكن نعملها عشان الديسكشن.
تمام تمام. زي ما قلت لك والله you are enjoying very much your talks. في سؤال بتاع بنتنا اللي سألته قبل شوية، أنا ما متذكرة الاسم، اللي هي إحنا متى نعمل كور بايوبسي ومتى نعمل فاين نيدنج اسبيريشن سايتولوجي وكده. أنا دايرة أقول لها الإعراب بتاعت الفاين نيدل اسبيريشن سايتولوجي disappearing، لكن مرات بنستعملها متين. نستعملها مثلا إذا عندنا
الاكزيلا.
axillary lymph node. أيوة axillary lymph node suspicious بنكون
مم.
بنعملها. sometimes زي ما انت قلت اليانج ladies الواحدة بتكون fibroadenoma، أو يعني انت you suspect إنها it's not، يعني زي ما قلتي حاسة الدايجنوز ممكن يكون راديولوجيكال، لكن مرات بيكون عندك suspicious كده انه دي يا اخي فايبر ادينوما ولا ايه تيبيكال فايبر ادينوما، ولا it could be malignancy ولا it could be phylloid. فزمان كنا بنعمل الفاي نيد respiration cytology. now the gold standard الترو كات نيدل ولا الكور
كور بايوبسي.
بايوبسي ولا الماموتوم، يعني دي هي الحاجات الحسه يعني.
والفاكيوم. يا
يس الفاكيوم
الفاكيوم
بالماموتوم.
especially for intraductal lesion.
ايوه 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 ايوه. فاليوز بتاع الفاين نيدل اسبيريشن سايتولوجي بيبقى فيري ليميتد، لكن ما بنقدر برضو نحن وي ديناي الامبورتنس بتاعتها في حتتنا في السودان الريموت ارياز، اللي هي يعني ما بيكون عندهم الفاسيلتيز بتاعت التروكات نيدل بايوبسي. ف
They can do it if there are malignant cells, then they have to proceed.
they have
If
to
it is negative,
have
they have to do excisional, at least excisional
yes
biopsy. If
yes
it is
yes
positive, then to
yes
manage the case as malignant.
yes yes yes.
Mhm.
ف I hope إنه this is answers الكويشن بتاع بنتنا. I enjoy very much حكاية الميست cases، لأنه يعني أنا دائما بقول للبيشنس it's very difficult إنك to say إنه this is a benign lesion or it's malignant. It's very easy لكن it's very difficult انه الليجن لو شويه فيه اي changes انك تقول للوحده والله this is benign. فدايما يعني بيكون في challenges، يعني في ابسط
especially
الحالات.
nowadays with increase familial. I suspect in Sudan we have a lot of familial cancer, okay, and genetic mutation more than expected internationally. And I raised that possibility in that lecture, okay, but I didn't find any of the seniors to discuss it with me. Okay.
والله يا مس رباب،
Mm.
ان احنا عملنا study مع دكتور طارق، الله يباركك. حاسه خلاص كده انا كنت بفتش للاستادي بتاع طارق دي ونسيتها. عملنا الانسيدنس بتاعت الفاميليا البريست كانسر عندنا في
Mhm.
السودان، ولقينا it's a quite number. It's a
Yes.
quite good number. انا ما عارفه طارق هو
Yes.
قدم البي اتش دي بتاعته دي ولا لسه،
Yeah.
لكن
I suspect that.
لقينا. ايوه
I raise that questions. I raise it.
ايوه يعني عملها مع دكتور طارق الفكي، دي البي اتش دي بتاعته، وانا كنت سوبرفايزر معاه.
Mhm.
فيعني لقينا كمية من الكيسز، وطبعا overlooked ليه؟ لأنه we don't ask for
We have
البراكا 1 and
counseling,
BRCA 2.
genetic counseling. We have no genetic counseling.
أيوة،
Yeah.
لأنه it's expensive و it's not available، وعشان حاجات
Mhm.
كثيرة جدا. I
Mhm.
hope إنه الحرب دي تقيف، والناس ترجع تحاول يعني تطور في السودان. ربنا يفرج علينا إن شاء الله بإذن الله.
طيب اكسكيوز اللكشر الجايه ام ار اي يا جماعه، والناس ما فاميليار بالام ار اي. تسمحوا لي انه امدد الزمن ولا بس اجرها لكم بسرعه في الهاف ان اور زي ديل؟ يعني اشرح شويه ولا لا؟
Yes, yes,
ها
أشرحي
please.
لك
This is
أشرحي
Nadia
لك
speaking.
رباب.
ناديه. you are
أشرح
welcome
أنا
ناديه.
حاسة اللكشر الفات I would have loved it too long.
أشرحي لك ما شديدة.
لا ما شديد، لا لكن انا في الالتراساوند دي، عيني في الالتراساوند دي، عرفتي انا يعني حتى كلفتكم، يعني عرفتي
هاي كلفتينا.
عايله كلفتكم لانه الزمن، عرفتي يعني الموضوع كبير والزمن بسيط.
والكيسز كثيرة حلوة شكلها
ما
جميلة.
يلا انا عملت يعني a lot of majority from my experience.
Yes.
Majority I select some cases from the literature just to emphasize على certain points, especially nowadays the high grade cancer and the triple negative cancer in young
كثير.
ladies. Okay, that is why. And regarding the MRI, the majority of the audience are not familiar with breast MRI. If I just go like that, the same as the mammography and MRI, and
ما ينفع.
it will not. فأنا شوف ناس وشاح قالوا ما
دكتورة
ينفع ناس دكتورة نادية.
معلش
رايك
ممكن
كيف؟
أسأل سؤال قبل ما تدخلي
يا
في
دكتورة رباب.
MRI؟
أيوة.
دكتورة رباب.
يا
yes.
دكتورة
أيوة.
معلش
دكتورة
ممكن
رباب.
أسأل سؤال بس قبل؟
اتفضلوا يا جماعة،
عايز أسأل
اتفضلوا ما
عن
في مشكلة.
طيب سؤالي يا دكتورة
when I
هل
could
ممكن
repeat the
في one
mammogram.
patient
في اتنين
ممكن في
بيسألوا في
one
معلش
نفس
يا
patient
السؤال
جماعة
يا جماعة،
two
واحد ينتظر
pathologists؟
سألوا
الثاني،
لبابا.
واحد
You can
ينتظر
start.
الثاني.
Yes.
You can ask your question دكتورة لبابا.
Okay. مساء النور everyone. ممكن في one patient يكون عندي two pathologies؟
يس هتشوفي الآن في الام ار اي ليكتشر تو باثولوجي.
طيب because I have a relative of me هي يعني في بداية الفورتيز. الفيرست diagnose كان عندها كارسينوما انسايتو، وعملوها ماستوكتومي was axillary clearance و with radiotherapy، لكن تقريبا أخدته very late. بعد two years we have another diagnosis in the other breast, which is invasive ductal carcinoma. فلأنه أنا by the way registrar of internal medicine فكنت confused هل هو من البداية هو invasive ductal carcinoma وحصل له ميتس للother breast ولا هم two pathologies. This is the first question. The second question إنه اتكلمتوا عن الفاميليال بريست كانسر وبس أنا داير أقول إنه مش إنه يعني الموضوع إنه بس just familial breast cancer إنه حتى الفاميليال breast cancer associated with other familial cancer يعني
mutations
غير ناس
genetic
البركة
mutation
1
you mean
والبركة 2.
yeah genetic mutations
Yeah.
when we talk when we said familial we mean not only running in family we think يعني we meant that even the genetic mutations included in it, the BRCA mutations and those. You have seen this, my patient, the 20, يعني one or two from the literature, but those 26, 25 patients on mammography and some of on MRI were my patient.
Okay.
Presented as young. Regarding your patient, bilateral disease, there are many scenarios in such case, and it is difficult. It is complex. Yani, I cannot just take it like that and tell you it will be the same, it will be separate, but you can discuss it with us later in more details, خلاص, and if there are available images and a lot of things, then we can decide. Okay, if it is the same or not, or synchronous cancer.
Okay, unfortunately the patient here passed away one year ago, لكن تخيلي لسه في دوكومنت للإيمجين وكده يعني.
No problem. ربي يرحمه ويتقبله القبول الحسن. بس نشوف الدوكيومنت. طيب ما في مشكلة. خلي الشباب في يعطوك الرقم بتاعي كونتاكت مي بعد ما نخلص من أكتوبر ده، لأننا ناو يعني very busy. وإذا ما في حد عنده سؤال يلا ننتقل للإم ار اي. ومعلش الإم ار اي هكمل ال 40 دقيقة بتاعين الإم ار اي، يعني ال 10 minutes بتاعت الكويشنز هدخلها في المحاضرة. هحاول أكون سريعة، لكن يعني شوية كده أهدأ من الاثنين اللي فاتوا.
طيب احنا ممكن نخليها 45 دقيقة يا دكتورة رباب، نخليها 45 دقيقة إن شاء الله.
طيب ممتاز، خلاص كويس جدا، جزاك الله خير. لأنه شايفة قالوا ما يعني
شايفة الناس متواضعين، فخلاص ممكن نخليها 45 دقيقة إن شاء الله بإذن الله، على أساس إنه باي 8 نكون خلصنا يعني إن شاء الله بإذن الله.
ما في ربع ساعة في الدكتورة هتقدم.
نعم،
الدكتورة من سيدرو هتقدم كيس ديسكشن.
أيوة
40 دقيقة، مش 40، ربع ساعة تكملي بيها. يلا خلاص نبدأ عشان الزمن. نخلي الباقي كله لآخر
يا بوس.
أيوة.
They are asking for a break for the brain.
عايزين بريك؟
يبدو لي
نهاية أفضل نواصل ونخلص.
أوكي.
لو في ناس بتطلع عندهم جام ممكن يعني يصلوا ويحصلونا إن شاء الله، عشان نحاول نخلص في وقت مناسب، لأنه بعد دكتورة رباب تاني في دكتورة حتقدم، فكده حنطول على الناس.
Is it shared?
No, not yet.
Not yet?
Yes.
Okay. Let me. Okay. Shared. Shared?
Yes.
Shared now.
نبدأ. Okay. Yes. The next session about can breast cancer be overlooked on breast MRI, its fears and pitfalls. Breast MRI is the third chair in the orchestra of breast imaging. Okay, and it appears that it has been increasingly used for both detection and characterization of breast cancer with a sensitivity approaching 100%, higher than mammography or ultrasound and even tomosynthesis. And MRM is used for the diagnosis of breast cancer to characterize equivocal findings, staging before treatment planning, detecting an occult primary cancer, evaluating response for neoadjuvant chemotherapy and breast cancer recurrence, and also assessing breast augmentation and reconstructions. Regarding its pitfalls, not all breast cancer are seen on MRI due to lack of enhancement and other factors, resulting in a false negative studies, reducing its sensitivity. So this is regarding the detection, regressing or decreasing the sensitivity. On the other hand, misinterpretation of artifacts, normally enhancing structures, and benign tumors, insufficient use of ACR can result in mimickers of breast cancer and affect its diagnosis, resulting in a false positive studies, reducing its specificity. So what is false negative on MRI is that cancer is not visualized at MRI and is instead diagnosed with another imaging modality. Despite the benefits of breast MRI as valuable in the detection of cancer, still some cancer can be overlooked. Okay. Our learning objectives or the goal of these lectures is to recognize classic MRI features of certain pathology and investigate main reasons for false negative MRI result, describe broad categories of errors and differentiate between perceptual and cognitive errors, illustrate some common artifacts and pitfall examples, and provide some tips and potential strategies to overcome these errors. Identify some features of a specific subtype of breast cancer lesions do not enhanced on MRI. MRI visualization of a lesion or cancer on breast MRI based on the neovascularity and contrast enhancement. If you can see here, this is pre-contrast image. The parenchyma on the left breast simulate the lesion on the right side. Okay, it is a complex type of the parenchyma, but both contrast definitely differentiate between the normal parenchyma and the invasive lobular carcinoma in the right breast seen as an speculated intensely enhancing mass with linear non-mass-like enhancement extending to the nipple, unlike the anatomic abnormality detected on ultrasound and mammography, the margins perception based on the lesion interface, but on MRI based on the take-up of contrast. Benign breast diseases can enhance sufficiently to raise the suspicion of malignancy as in this fibroadenoma compared to this cancer, but there are typical features regarding enhancement of cancer as compared to the benign masses. The cancer usually due to neovascularity and neoangiogenesis has avid rapid contrast enhancement or wash in contrast within the first 2 minutes. Okay, that make it very clear from the adjacent not yet enhancing parenchyma. And for the same reason of neovascularity, neoangiogenesis that demonstrate rapid washout. Here, intensely enhance and immediately get rid of the contrast, rapid wash in and rapid wash out in comparison to the benign mass is usually progressively taking the contrast. However, this pattern is not seen in association of all breast cancer, and that is why interpretation of breast MRI remains a challenging task. As in this example here, a patient of lobular carcinoma perform MRI for staging, demonstrate the lobular carcinoma here and a similar lesions in the contralateral breast, biopsy proven to be just mixed benign fibrocystic changes. So breast MRI specificity remain moderate, 65 to 79, due to limited ability to differentiate benign pathologic process that enhance from malignancy. So it is a problem. It is challenging. Why? Because it pick any, almost all the abnormality. It is sensitivity approaching 100, but to differentiate, okay, a little bit challenging and less, resulting in less specificity. However, using advances in the breast MRI techniques improve MRI specificity, like the ADC, the fusion weighted, okay, with ADC and the spectroscopy. The same main causes for all breast imaging, technical, biological lesion, patient factors are reader factors, and the pathway of failure on MRI here include either lack of enhancement, okay, the non-visualization of any enhancement because the lesion itself or the tumor did not enhance, or missed enhancement, failure to detect the lesion at all, perceptual error, or misinterpretation of that enhancement, failure to recognize or characterize that lesion correctly. This is the cognitive error, and mismanagement, which is the failure to manage the lesion correctly. So at the end, this will lead to missing the opportunity to diagnose breast cancer. Under the lack of enhancement, there are many reasons. We'll go through examples of these. Technical factors include artifacts that obscuring or mask underlying enhancement, the lesions located outside the field of view, poor or inadequate contrast injections or excessive compression, improper time of examination in premenopausal women. Okay, so if we have lack of contrast before interpreting that there is no contrast enhancement, we should first make sure that the technique is adequate, and the patient, if the patient receiving chemotherapy recently or not, because it's going to affect, and the type of MRI contrast, all these factors can affect the contrast enhancement, and how we can make sure that adequate contrast reaching the circulations, checking the contrast in the heart, okay, in the vessels within the breast and retrosternal or internal mammary vessels, okay, look for the enhancement of the nipple and compare with the pre-contrast image, okay. This is an example of non-enhancing, okay, mass seen on T2 as suspicious mass, and on CT it was enhancing. And this a lobular carcinoma, usually challenging and strange. And here, these all are background parenchymal enhancement, and the mass here appear as non-enhancing mass, okay? No enhancement at all. And this is speculated mass, corresponding speculated mass on mammography, as well as on ultrasound. Why it does not enhance? This is one of the lesion factors, tumor intrinsic factors. There is lack of new vascularity. Some tumors, okay, like low-grade DCIS or low-grade invasive cancers, okay, and small cancers, less than 5 millimeter, some of lobular, some of the tubular, okay, and pure mucinous cancer, they have this characters and result in lack of contrast. However, the high-grade DCIS has been more often associated with strong enhancement, okay? Unlike the low-grade DCIS. The radiologist should exercise extreme caution in such cases and not recommend MRI instead of biopsy in case of resolving suspicious mammographic or ultrasound findings. And here we can see the examples of pure mucinous cancer, which does not show any enhancement on both contrast, very bright on T2 and is suspicious on ultrasound. The mismanagement, regarding mismanagement, is either inaccurate correlation between MRI and second look ultrasound and erroneous sampling of biopsy, might be from wrong lesions or importance. This signifies importance of placing an MRI compatible clip and repeat the MRI if there is discordance between the result or there is no ultrasound correlate that can lead to biopsy. In this example here, the patient has bilateral mastectomy and reconstructions for invasive cancer presented on the surveillance MRI with a lump, an enhancing mass in the right axillary region. Ultrasound demonstrate a benign lesion, no biopsy. So the mismanagement here, and it was proven to be a recurrent invasive cancer. Regarding the observer factors, either cognitive, clean misinterpretation, or perceptual lack of seeing the lesions. Okay, and under each of them we have a lot of factors. We will go through some of these by examples. And regarding the missed enhancement, the missed enhancement is the perceptual lack of perceptions, failure to detect the enhancement, poor conspicuity, either the lesion subtle, small, atypical appearance, satisfaction of search, distracting lesions, and so forth, reader fatigues. Okay, here this is a missed enhancement due to masked by overlying subtraction pseudo lesions. Okay, artifact obscuring them. So it is essential to review the native post-contrast images, okay? Not just to pass it, there is no enhancement, and that is. Again, this is our patient having poor fat suppression that obscure suspicious enhancement on the left side due to underlying invasive cancer. So to take home message here, it is critical to examine all MRI images for adequate technique before interpreting MRI examination. And here, this is what we call it the crescendo sign artifact in post-contrast image. This is a black area obscuring underlying suspicious abnormality, and the same, we have to check our images before start interpretations. And the other things is that, okay, the lesion can obscure by increased background parenchymal enhancement. If it is moderate or marked background parenchymal enhancement, if we have any small evolving lesion, definitely is difficult to be evaluated in this MRI dense breast. Okay, again, this patient having left breast cancer obscured by this dense background parenchyma because it was performed in a third week in a premenopausal woman. Can you compare it with this background parenchymal enhancement, which is very minimal, and make it easier to detect this clump segmental enhancement in the left breast? The MRI was performed at the second week of her cycles. This is a missed cancer because it is too tiny, too small. This is patient having mastectomy and reconstructions, okay? And at the junction between the reconstructed tissue and the native tissue, there is small focus of enhancement was missed as part of the background parenchyma and much easier appreciated in the maximum intensity projection here. So always check for these tiny lesions, tiny enhancement, the maximum intensity projection. 6 months follow-up demonstrated that progression of the mass, okay, and it was confirmed to be a recurrent invasive cancer. Regarding the misinterpretation, which is a cognitive or recognized error, there are many reasons or many causes of which, but the most common is benign features. The lesion presented as a benign features or a non-mass-like enhancement simulate background parenchymal enhancement and then misinterpreted. Okay, here we have these lesions missed because it is adjacent to vessels. Okay, this is it's seen but considered to be part of the vessels. It's a focal non-mass-like enhancement representing a cancer. After 2 years, it becomes more clear. So we have to avoid errors by utilizing all available prior examination for comparison. Here we have 2 patients, okay? Both share that are high risk, okay? They are a high risk patients, okay? This on the left demonstrate sagittal view, demonstrates small focal enhancement was not seen neither on mammography or ultrasound. Under MRI guidance, pathology result revealed invasive ductal carcinoma. And the other patients here, this is the first image, demonstrate a faint focal area of enhancement misinterpreted as background parenchymal enhancement, and recommend 6 months follow-up. Now it is frank enhancing mass and proven to be invasive ductal carcinoma. So we have to consider clinical information to avoid misinterpreted enhancement. Okay, if the patient is high risk, we have to be cautious. Again, this is the missed or misinterpreted lesions, okay, cognitive errors. This lady, 60, about in her 60s, presented for routine surveillance with history of 3 years conservative therapy of triple negative cancer. And if we look here, there are small scatter enhancement, but this is a little bit more dominant. It is about 4 millimeters. So, and it was low on T2. So it has to be considered as suspicious, but they gave her chance of 6 months follow-up to retain double size millimeter and was a recurrent triple negative breast cancer. So any dominant focal enhancement that appear distinguishable or different from the remain, it has to be considered suspicious for malignancy, and we have to take care, especially in when we have a complex background enhancement. Another patient here, okay, this 65-year-old have her mammogram was negative, but it was heterogeneously dense, supplemented by screening MRI demonstrating this focal of enhancement here in the left breast, okay, presumed to be intramammary lymph node because it was in the upper outer breast, though it was low at T2, and usually intramammary lymph node supposed to be right on T2. And 6 months follow-up, the lesion increasing, progressing, and proven to be invasive cancer. and it was seen here on second look ultrasound, and it was sorry, it was DCIS, not an invasive cancer. So the take home message is that we should not always assume any lesion, small lesion in the upper outer quadrant as intramammary lymph node without seeing a typical intramammary lymph node. And we have to consider that this is the same location of the most common breast cancer in the upper outer quadrant. So we have to consider cancer more than to consider axillary lymph node, intramammary lymph node, unless it is very typical. And also we have to consider the T2 hyperintensity. Okay, when the lesions is small, okay, on MRI, it will be beyond the resolution of characterizations of its morphology. So it will appear as homogeneous enhancement with the benign morphology. So we should not exclude cancer in such type of small lesions. Here we can see this is a fibroadenoma, this is lymph node, but these are cancer, okay? So we have to integrate all of the sequences, MRI sequences, and looking and seeking any suspicious findings or suspicious morphology. And according to the BIRAD Atlas, a focus that lacks T2 hyperintensity or fatty hilum should be considered as suspicious for malignancy. And also we have to consider the kinetics, and if the kinetics curve is plateau or type 3 washout, so we have to proceed for biopsy, as we have seen in this case here. This is proven to be fibroadenoma, but this one proven to be invasive ductal carcinoma, while both associated with a plateau type 2 curve. But also we have to consider the diffusion weighted images, okay? And low ADC is very predictable of breast cancer. Again, we have to consider the history. This lady presenting with a small benign morphology. And again, after 6 months, it is benign morphology. However, here it was the enhancement pattern, the enhancement increase and the pattern become more washout. So the characters of enhancement change and the size increase, but still with benign appearance. But if we look for the history, the patient high risk, it was a BRCA2 gene carrier, okay? And it was not bright on T2. So as we mentioned before, we have to be cautious while taking care of such patients, okay? Especially those with BRCA1 and BRCA2. Usually, or most of the time, they have a benign morphology. Why? Because they have a higher incidence of medullary cancer, which is associated with benign morphology, and also associated with a high nuclear grade that also associated with a benign morphology. And sometimes cancer over times started as benign morphology, but over time might change to suspicious features. Here, this is an example of medullary cancer presenting with benign morphology in BRCA1 gene mutations. And this patient is a 51-year-old, also BRCA mutations. Her MRI, screening MRI demonstrate this is very tiny lesions, okay? And it was bright on T2, so misinterpreted as a fibroadenoma. 7 months later, the patient, her MRI demonstrate significant increase in size of the lesion and change in characters, become more necrotic with rim enhancement and mural nodules. And here, this is still bright on T2, but this is the central necrotic area expanding the mass, okay? And the ultrasound, second look ultrasound demonstrated a suspicious lesion, and the biopsy confirmed triple negative invasive cancer. This is misinterpretations of internal septation in a cancer as a dark non-enhancing septations in a fibroadenoma. And there is a difference between the two, okay? This is the dark, this is the internal enhancing septations, while here, this is dark non-enhancing septa. And the dark non-enhancing septas it is not specific for benignity. It's high predictive for benign, but not specific. This is example of invasive ductal carcinoma simulating a fibroadenoma due to benign morphology and dark internal septations. So what is dark internal septations? They are non-enhancing septum, okay, or septations, which are sharp, smooth margins, low intensity, non-enhancing lines are visible within a mass throughout the dynamic, okay? And were initially described to have a high specificity in the diagnosis of fibroadenoma, but this thought now has been changed. It has progressive enhancement and are not bright on T2, okay? So nowadays become of little value because are seen associated with malignant phylloides and benign and malignant phylloides, as well as even invasive cancer. So it has little value and we have to be cautious. This is invasive cancer with dark internal septations, okay? This is, these here, a malignant phylloides. We can compare it with this fibroadenoma, having the same morphology and enhancement, okay? And bright T2. So this is very deceiving area of recognition or cognitive misinterpretations, okay? But we have to remember that even on ultrasound and mammography, we describe certain subtypes of breast cancer associated with circumscribed margins. One of these are phylloides, high-grade cancer, medullary, mucinous, intramammary metastases, XXX, other few, okay? So we have to consider other features. We have to consider the clinical. We have to look for all sequences. And again, benign morphology here. While this is a fibroadenoma and this is invasive carcinoma. This is a mucinous with benign morphology, one of which both are bright on T2. Mucinous is exception for the cancer on T2 to appear as bright. One of the cancers that appear bright on T2, okay? But one doesn't show, demonstrate lack of enhancement, while the other one demonstrates the suspicious rim of enhancement. So mucinous or colloid simulate benign and most of the time misinterpreted as myxoid fibroadenoma, okay? These three examples from my experience, the three of which, and even I have more, presented as T2 bright, even simulating the cyst, but the morphology was suspicious, okay? And both contrast demonstrate enhancement different from that of a cyst and proven to be an invasive ductal carcinoma, okay? Where T2 hypersignal intensity. Okay, this example, okay, we have, this is a high risk baseline MRI in a 44-year-old lady. Demonstrate bilateral lesions. The one on the right is more clear, Brighton T2, while this one here, okay, it is ISO, intermediate signal intensity to ISO. Both are both demonstrate enhancement on both contrast study. The left one, okay, with a washout type 3 suspicious kinetics, while the right one, this one, demonstrate persistent enhancement. The right is a mucinous cancer. And even if you look more or less more benign morphology rather than this one, a little bit demonstrates subtle suspicious features. And so, as we mentioned, that satisfaction of search. If you have seen lesion in one breast, you have to look and search within the same breast and look for the other breast so as not to miss cancer and to characterize each lesions separately. Take single lesion and characterize it in all sequence, then go and take the other one and characterize it in the other sequence, okay? And we can use the diffusion weighted images. Here, the diffusion weighted images demonstrate the difference between a fibroadenoma and a carcinoma having the same morphology and same intense enhancement, while the carcinoma demonstrate restricted diffusion with very low ADC. The fibroadenoma here demonstrate T2 shy. So it can help in differentiating between benign and also spectroscopy. And as you know, the elevated choline associated with malignancy can be also helpful. Lesion stability does not absolutely indicate benignity, okay? This is one area of challenge and misinterpretations, recognition errors, cognitive errors, okay? This is a small lesion. After 6 months, it was the same. But after 2 years, can you see it? Very typical malignant one, proven to be grade 2 invasive ductal, 2 centimeter invasive ductal carcinoma. So it was very small sub-centimeter. After 2 years, it become 2 centimeter invasive ductal. And this is stable, almost 3 years, stable intraductal papillary carcinoma. So avoid these errors by utilizing all available prior examination for comparison, reviewing or viewing all MRI sequences, consider the clinical history and conventional images to correlate. Here, these are examples of a high-risk lady having small enhancing lesions, okay, relatively look stable, okay? If you compare this with this, to 2010 with 2009, it looks more or less stable. If you compare 2011 with the year before, each year, if you compare it with the just 1 year before, you might say this is unstable. Compare the latest 12 with the 2009. Definitely, it is progressing. It is progressing. And this is the significance of comparison or comparing with different study for longer period. So it will demonstrate the growth of the cancer over time, and it will make it easier for the radiologist to say if this lesion is growing or not. Though the long-term stability usually reflects benignity, but there are exceptions, okay? Some cancer are growing slowly. And this is, again, this is the most recent, demonstrate here multi-regional or non-mass-like or regional non-mass-like enhancement clump internal textures, which is suspicious. But when they compare it with 1 year before, it was stable, okay? But comparing to the 2 years and 3 years, it was not there. Okay, so it was biopsy proven high-grade DCIS in a BRCA2 mutations patients. Okay, so it is important to compare all available prior examination for any change over time, and we have to consider high-risk patients. And this patient here in the first row here, you can see this is non-specific lymph node and intramammary lymph node. Both contrast here, we can see subtle changes misinterpreted as background parenchymal enhancement. But usually we have to compare the two sides. And if I ignore this with typical internal fatty hilum, but this one, if it is asymmetric to the contralateral, so I have to consider it as significant and pathological. And here, this is the follow-up demonstrate progression of the cancer is non-mass-like enhancement. And this intramammary lymph node and axillary lymph node, metastatic and progressing even in size. And one of the challenging area is the segmental enhancement, see, linear and segmental enhancement, which are alarming of DCIS, however, are seen in mastitis and fibrocystic. So really, in our practice is a challenging area and recognition errors. Here we can see different linear, okay? These are DCIS, this fibrocystic, and here seen in a scarring. But we have to consider, if we have seen it in a high-risk patient, we have to take it with considerations. And we have to correlate with the T2 and other sequences. Here we can see this clump enhancement here associated with an area of cystic changes in a case of fibrocystic, while this enhancement, segmental clump enhancement, and though it was bright on T2, but demonstrate area of a small area of washout in background intermixed enhancement of predominantly persistent but small washout area and pathological ipsilateral axillary lymph node in a high-risk patient, 64-year-old lady, okay? Ultrasound correlates 6 months follow-up, and it was proven to be invasive ductal carcinoma. Another area of misinterpretation and cognitive error is post therapy, okay? This is a post therapy. We should not always say that is post therapy changes and that is it. We have to be cautious and to give the patient chance at least of follow-up. And as in this case here, reported as post surgery, okay? And then this is non-mass-like enhancement, progressing, increasing, and proven to be DCIS after MRI guided biopsy, while in this the same post therapy case reported as maybe fat necrosis, proven to be a mucinous cancer. So RIM enhancement is suspicious for malignancy, but not always indicate malignancy. Not always indicate malignancy, but it is a really challenging area. Okay, put us in a dilemma. Usually feature of high-grade invasive ductal carcinoma due to central necrosis, with positive predictive value ranging from 79 to 92%. But can be seen, the pitfalls that it can be seen in a seroma, abscess, cyst, inflammatory cyst, fat necrosis, and hyalinized fibroadenoma. So we have to differentiate and to use and utilize all the sequences and to correlate with clinical and so forth. These are multiple examples of typical RIM enhancement in cancers. And what is helpful in this case is normal hormonal fluctuations. with the background of background of this parenchymal enhancement, and that demonstrate hormonal fluctuations and RIM enhancement that bright on T2 going with fibrocystic changes. And here this is typical fibrocystic changes, the cyst and this fluid levels, okay, not seen any intracystic changes on post contrast. This is usually it is thin, uniform enhancement surrounding completely around the cyst. This is again similar to this one, thin, uniform, surrounding, but I can see central enhancement. This is the central nidus. Presence of central nidus indicative of malignant type of cancer. And here, this is RIM enhancement, but associated with speculations and irregularity in invasive ductal carcinoma. Okay, yes, this is a relatively thick, okay, but uniform and bright, central bright on T2 in a case of proven to be just an inflammatory cyst. But in this case, it is thick but irregular from inside, okay? And corresponding to this RIM enhancement, T2 hypo signal intensity, this is highly suggestive of malignancy and proven to be invasive cancer. But still, we are in a dilemma and challenging regarding such RIM enhancement, okay? While this represents inflammatory cyst, this represents multicentric cancer. And again, this is a cancer, okay, with central necrosis. So if not typical cyst RIM enhancement, it has about 40% chance of being malignancy. Another area of challenge is fat necrosis. The typical fat necrosis is non-mass like enhancement with RIM enhancement, and the non-fat SAT image demonstrate a fat signal, okay? But we have to be cautious in such case, okay? And we should not always report it as fat necrosis. We have to correlate with mammography, ultrasound, and so forth. These examples, it looks suspicious, okay? It looks suspicious in post-operative case, so they proceed for biopsy, but fortunately was proven to be fat necrosis. However, as we mentioned, we have to be cautious and we should consider it as suspicious. We should say, since this is post-surgery, it is bright on T1, so that means it is a fat necrosis. No, non-fat, no. We have to make it suspicious because not all bright T1 signal intensity indicate that it's fat. This is the cancer here, okay? It is low on T2, surrounding with edema and corresponding enhancement, and the edema not enhancing, and the corresponding bright T2 iso to the surrounding fat. But in this case, it was not a fat, okay? This is not fat signal intensity. So we have to correlate with all signals and make sure, and also correlate with diffusion weighted images. And as we mentioned, the presence of decreased ADC provides strong evidence of malignancy, okay? So this case, it was a cancer, it was not a fat necrosis. So though, can you see the high signal intensity here? Iso to the fat. So we have to be cautious, not all cases to label it as fat necrosis and misinterpreted cancers. Also, the false negative result due to perceived benign kinetics. If we have a benign kinetics, it doesn't always mean that this is not a cancer. These are my patients. These two are my patients having persistent kinetics. But this is the area this is the lesion, high grade with rim enhancement. And this non-mass-like enhancement, okay, most of the time are associated DCIS. And this one, it was proven, pathologically proven to be DCIS. In my practice, I have seen a lot of DCIS, unless it is a high-grade DCIS with a washout curve. The majority of my patients of DCIS I have seen in my practice were associated with type 1 curve. And according to the literature, type 1 curve can be seen in 10% of breast cancer, mostly invasive lobular and DCIS, and can be seen in patients on chemotherapy treatment. So the tips here, we should take multiple areas of region of interest within the same lesions to make sure, and we have to consider the morphology first. The kinetics is adjunctive to the morphology, supplementary to morphology. We should not depend on kinetics to exclude cancer while morphology is suspicious. Regarding the axillary lymph node, also is an area of challenge in interpretation of MRI. And in this case here, I can see I can see an enhancing axillary lymph nodes, okay, and the patient having small but retroareolar predictive site. So I'm expecting that this axillary lymph node to be metastatic because the lesion in a rich area of lymphatics. It's in a predictive locations, okay? But sometimes the evaluation is difficult. Yes? I'm about
5
at
minutes
the end
left.
of the slides, okay? I am about to finish.
Okay.
Okay?
Okay.
This is the, when we correlate with diffusion, you see, this is a diffusion. These lymph nodes demonstrate restricted diffusion. This is a diffusion weighted, and this is the ADC color map, okay? And even the measures of ADC within the range of malignancy, and it was proven metastatic lymph nodes, okay? I'm not going to talk much in this area. This is almost the latest or the last area of challenge in my presentations, which is the nipple involvement, nipple contrast. And as you know, the nipple involvement by malignancy upstakes the disease and make the patient non-eligible for nipple sparing mastectomy. So we have to be careful in the assessment, and this is really a tricky area to be assessed and very common of base perceptual and cognitive errors. Okay, and we have to know. Okay, unilateral, bilateral enhancement involving the nipple only or extending to the nipple areolar complex. Okay, is it a physiological or pathological enhancement? Is it, if it is pathological, due to benign or malignancy? If I have seen a malignancy, is it the enhancement really extension of the disease, and how far from the nipple? They consider it two distance from the nipple, but now even 1 centimeter can be considered to be non-involved, okay, the nipple areolar complex, unless we can see enhancement or extensions. So there are many questions, okay, when you are evaluating just the enhancement of the nipple. And usually it is bilateral. It can be inflammatory. It can be neoplastic. This patient has far away malignancy and bilateral nipple symmetric enhancement not involved. But here, there is a questions. I can see enhancement, cancer, okay, clump segmental enhancement extending into the nipple, and I could not appreciate the normal structures of the nipple. So it is also here, I could not see the structures. Sometimes just by rubbing okay? Rubbing by clothes in the those who are runners, okay? For long distance, they can rub the nipple and result in abnormal enhancement. If you look for this case here, according to the writers, they said that this, yes, we have seen here, this is flap, reconstructing flap, and this is recurrence. But they analyze this case as a DCIS with ruptured duct rather than a mass infiltrating the nipple because the structures of the nipple are preserved. We can see the dermal enhancement and non-mass and non-enhancing zone intact. So these are a lot of challenges, but what can I just summarize for you just to know what is normal regarding the nipple? Okay, the anatomy of the nipple on MRI. Here, this is the base of the nipple, and this is the papilla, okay? And what we have seen here within the nipple is the patchy enhancement, which is considered normal. Patchy and linear enhancement are the normal enhancement. And here I can see the epidermal enhancement. This is the thin epidermal enhancement and the dermal non-enhancing zone. This is, they call it non-enhancing zone is intact. When we can see it intact, that means the enhancement beyond which is a normal type of enhancement. And there are a lot of talk and a lot of descriptions regarding this challenging area. The enhancement can be minimal, can be moderate, can be mild or marked. The nipple, as you know, can be everted, flat or inverted, can be affected even by the technique, you see, can be flattened by the coil and enhance it more. And there are a lot of issues regarding this. And thank you regarding my presentation. Now I have a question for you. What could be the cause of overlooked cancer in this case? What could be the overlooked cancer? Any volunteer? Okay. If you don't know, most likely small size. You see, this is small size, but we have to be cautious because the patient high risk. Okay. And this is a solitary on baseline. Okay. It was not bright. They mentioned that not bright on T2, but there was no ultrasound correlate. So either to go for MRI guided biopsy or to follow the lesions until slightly become larger and check on ultrasound, okay? And it was a DCIS on MRI guided biopsy. And as I mentioned in all all breast imaging lectures, our strategy, we have to consider it all. And regarding the incidental enhancement on MRI, which was not seen on conventional images, there are three strategies. Either the first strategy, we have to do second look ultrasound to check if there is a corresponding abnormality, then we'll use ultrasound as guidance. Otherwise, we can follow the lesions, repeat an MRI at another suitable time. And the third strategy is to perform MRI guided biopsy. In conclusion, careful development of thorough search pattern, review of all imaging sequence and clinical history is critical to avoid perceptual and cognitive errors and cancer missing on MRI. It should be re-emphasize that a definitive diagnosis is always based on a comprehensive analysis of all observed signs to reach a correct diagnosis. Despite this, A small number of false negative cases are inevitable, as certain cancer may not demonstrate significant contrast enhancement, and therefore MDT is crucial for correct management. Thank you very much.
Thank you very much, Dr. Rabab, for this valuable presentation. I'm sure there are a lot of questions. However, we're going to leave the questions at the end of the symposium, at the end of this day.
Okay.
I would like to present our next speaker, Dr. Amna Ahmed. She's a medical doctor currently working in the UK, and she's going to present a case study about tracking subtle changes in breast imaging. Welcome, Dr. Amna.
Hello. I should stop my share so as she can share her.
Can you see my screen? Can you hear me well?
No, your voice is not very clear.
How about now?
Yeah. No.
All right. Just let me. My screen. Can you see my screen?
Yes, I can see it.
All right.
Can you open the first slide?
This is the first slide.
Yeah.
No.
All right. Can you see my screen?
Is this your screen or Dr. Rabab's?
Make it big. Only make it big. Make it big.
Okay, I can. Maybe if I increase. No, this is a lot.
No, not the size. Not the size. Regarding the view. Go to view.
Yeah, slide share. Okay.
Okay.
Yeah, I can see your
View
screen.
view the slides. It will become big.
You mean from here?
This view here in the air.
Oh, okay.
I don't. Yeah.
Yes. Perfect.
Yeah.
Thank you.
Okay.
Thank you. My name is Dr. Amna Ahmed, a medical doctor here in the UK, a facilitator at Sudan Eco Center of Excellence. We are honored to have with us today Professor Rabab, who generously shared her knowledge and time. We sincerely thank her for her valuable contribution. Today, I'm going to present a case highlighting the pros and cons of ultrasound, covering the period from 2014 to 21. The case detail were provided by Dr. Rabab, who will join me during the presentation to share more insight. I hope you find the case both enjoyable and informative. So we're going to track the subtle changes in breast imaging. So in 2014, the case presented for a screening mammogram, which showed no abnormality. As you can see here, there wasn't no abnormality, no nodular changes, but like this established a baseline for future comparison. In 2015, the mammogram finding, first of all, there was a nodular opacity detected in the left breast, and in general, the mammogram was ACR2 density pattern. It was like a scattered fibrogranular density. Hence, what was the next step to be done? Because of the nodular finding, they have done ultrasound, which showed bilateral multiple echoic and hyperechoic nodules considered benign fibrocystic changes. Plus, there was a significant lesion was identified, oval parallel hypoechoic, measuring 1.3 at the 12 o'clock position, looked benign and calcified, along with ductectasia bilaterally. Overall, they consider the case as fibrocystic changes. This is the ultrasound finding. At 2015, they considered it at 12 o'clock, and it was calcified. So the case missed 2 mammogram in 2016 and 17. And then she came again in 18. First of all, the mammogram, there was a parenchymal stability, similar nodularity and density, as you can see here. The ultrasound showed same lesion at 12 o'clock, but they saw that it was slightly regressing, smaller in size. But the weird thing was that the lesion wasn't calcified. So it was in 12 o'clock, but it wasn't calcified. So so maybe it was the same lesion, or this is a new lesion. So here, in 2018, if we want to compare it to 2015, as you can see, they considered it as the same lesion, but decrease in size. But as I mentioned, it wasn't calcified. So this is when she presented in 19. This is her mammogram. So there was a lesion at this time, but this time they reported it at 9 o'clock. It was calcified, benign appearing lesion without comparison to previous. So they didn't make a comparison. They just considered it at this time it's at 9 o'clock. But like the weird thing is that there wasn't like new lesions that was mentioned in 2018. So if we want to compare here retrospectively to 2015, there was a finding here, but we can speak about it later when we reach 2021. So here in 2021, the case has been, this ultrasound has been done by Prof. Rabab. So what she found that, first of all, the 9 lesion mass now is calcified and it's increasing in size and cutting the edges tissue. So now it's the features are malignant in nature, as you can see. It's now she considered it as a 9 o'clock mass and it's calcified. Again, there was architecture distortion, left compared. I can just give me a second. There is a lot of pictures that I maybe found. I'm sorry.
Okay. Proceed.
Okay,
No
so there were
problem.
there were a lot of changes. One of them, there was architectural distortion, and there was like cutting adjacent tissue. And if we want to compare the lesions now, so Dr. Rabab, she compared the lesion that she found in 2021 to a lesion that has been shown in 2019, and she found that there was a demonstrative inferior margin finding, highly suspicious. So there was like infiltrative finding even back in 2019. So yeah, there was like a lot of like pictures. I don't know why I can't get it now, but yeah. And she mentioned that the lesion now it's 9 o'clock. So what happened is that the operator who has done the screening previously, because like he was looking at a specific from a specific site, so he reported it at 12 o'clock. But obviously it was a 9 o'clock, and it was showing like malignant changes, and it was like even like reaching like the wall, the breast wall. So the takeaway messages is that, first of all, the problem here was that there wasn't like any comparison to older images. So we have seen like in 2018, they reported it as a not calcified. However, in 2015, they reported it as calcified. And again, because there was like a background of fibrocystic changes, so it made it like look like more benign, and they didn't like raise concerns about that. Another taking point is that when you do the ultrasound, you need to be like, you need to take your time to be very slow, to look from different views to make sure that you're not missing anything. And of course, like regular follow-up. And we need to remember is that cancer, breast cancer is easy missed, especially when it's present in the taper zone, forbidden area. Needed special attention for any subtle suspicious features. Thank you. I'm sure that I have missed like a lot of points because like of the images that was here. It was very informative, but Dr. Bob can give us an insight about them.
Okay, can you leave this image only? Leave this image, this ultrasound image, okay?
Yeah.
Okay, the scenario of this case is that she has, yes, she has slowly progressing malignancy in extreme medial breast. And unfortunately, I left the hospital before receiving the biopsy of this lady, but I suspect that this is most likely it will be lobular carcinoma. Because even when she was presented on in 2020, okay, there was no palpable abnormality in her left breast, in spite that she has 3.5 centimeter mass in extreme 9 o'clock of the left breast near to the midline. And the lesions, the calcified lesions, a little bit medial to a little bit more toward the nipple from that extreme at the same line at 9 o'clock. It seemed I found that it is interconnected with a tubular structures, okay, to that mass. At the beginning when I was scanning, I found that this area, the mass itself, I reviewed all the previous images and I could recognize that on mammography, the lesion was progressing. And yes, she has, the reason that had been missed, that is the background fibrocystic changes. And not taking the comparison with the previous more meticulous. So I spent more than 1 hour correlating all of her studies and the current study at that time, and I could appreciate that nodule progressing in size, and yes, the one is calcified, the calcified one, and not only that, there are areas of breaking capsules. It is oval, but there are breaking capsules. It was suspicious, and there is band extending toward that to more medial. I trace it until I could find an area of architectural distortion. I compare it with the other side with with a lot of angulation and searching. Then I could appreciate within that mass, within that architectural distortion, the architectural distortion is almost 4 centimeters, within which there was a typical malignant mass measuring to 3.5 centimeters. And from that mass, there was deep infiltration into the chest wall muscle. Okay, so that most likely, and the oval, can you point to that oval lesions in the prepectoral at the region, at the apex of the prepectoral left side? Yeah, on mammography.
Yeah, here?
Yes, that is the one. It was there in some mammography. Yes, it was there, but it was ignored as part of the nodularity. And because the primary cancer, it was so extreme medially, okay, that is, it was outside of the field of view. It was outside of the field of view. That is what not seen. But if we just look at all mammography, we can see subtle adjacent architectural distortion extending a little bit, progressing in this series of mammography. And it seemed to be just slowly growing cancer with the afferent. Can you show this ultrasound image? This one, can you see my cursor or not?
No,
not seen.
شايفينه ظاهر.
شايفينه؟ It's
أيوة.
okay. Okay, it is good. I thought, okay, if we compare this, this is the area of architectural distortion in extreme medial left breast, compare it with the normal right breast, and even overlying skin is thickened. And this is the area of architectural distortion, and there was a mass within this area of architectural distortion. Mass. Can you see the speculation? There was a mass. And there is one more clearer images, but she missed it. There is here, this is tracking from the mass going down to the chest wall, and there was clear infiltration of the chest wall seen by ultrasound. It became locally invasive cancer. And this, if you look here, there was a band like having the same echogenicity of both the mass. Even the mass here, the primary cancer, was calcified and having the same texture as this mass. But this is the primary, and this is intramammary lymph node, and that was most likely the afferent, infiltrating afferent lesion extending from the mass into intramammary lymph node. Okay? Unfortunately ended with
I can find it.
معلش يا دكتورة رباب، لو جبتوا أول ماموجرافي في مستشفى السكرينينج ده كان
outside Sudan.
من أول ماموجرافي أنا شايفة لي calcification suspicious من أول ماموجرافي. يعني لو جربت الماموجرافي ده.
Yes, here if you look here, okay, that was the lesion. Okay?
Yes, yes.
That is the lesion. Okay.
أيوة.
And it is here. Okay, that is the one.
أيوة.
It is small. Go for the next one. Go for the mammography 2000.
لا هي it is progressing، يعني واضح إنها progressing.
Can you see here now the distortion, and even in the CC view now it become more clear. Go for the next mammography.
Very strange، يعني أنا عشان كده قلت ده مستشفى يعني واضح.
Okay, can you see now? No, but because of you see, this is the area of fibrocystic. It is always challenging because the lesions, okay, progressing and regressing, and this is the value of companion images, okay, ultrasound along with mammography. Based on mammography may or may not, but using ultrasound along with mammography, we have to be careful in evaluating our lesions, our patients. Okay, now the lesion, look for this architectural distortion going more deep. That is the connection going toward the extremely deep malignancy, which could not be included in the field of view because it is near to the midline. Okay, go for the next. And unfortunately, while evaluating lesion, I have to take all of the characters. Okay, this lesion very unlikely to say, again, go back.
Yeah.
Because sometimes while angulating the image, ultrasound image, sorry, the ultrasound image demonstrating this one and the next one. Yes, this one. If we consider this one, this is at 12 o'clock. And this one, now, it is 9 o'clock. But around the same regions, around here, okay, seen here. And if I have to make and have to take all the characteristic feature of the lesions to say and to make sure that it is regressing. Especially if it is regressing, I have to make sure that the lesion is regressing. It occurs in fibrocystic, yes, it happened. In fibrocystic, it happened. The lesion can regress, complicated cyst, but that lesion was calcified. I have to make sure this the same lesion, regressing lesion is calcified. And these lesions, even they didn't pick it up in this study. that is the challenge of breast imaging. Okay, and then go for the next. Look now, look for the lesion, how it's getting larger. Even by measurements, it's getting larger, getting larger. And as I showed, I will show it to you again, inshallah, the whole images together. And I show, and it is obviously here, for even from 2015, it is not a circumscribed one, okay? And there is cutoff here in the tissue, and this is not a pseudocapsule. There is a reaction surrounding the lesions. So it was a suspicious intramammary lymph node, and I hope that okay, no problem. We can see it, and here that is the intramammary lymph node, and that is the primary cancer. We can discuss it another time, bringing almost all the ultrasound images.
Yeah, أنا متأكدة.
Thank you, Anna. You presented very well. And
طيب
as we mentioned,
واضحين؟ كده كيف شايفة؟
Yes, it is good, but the problem, the other ultrasound images, okay, are really important to show the infiltration of the chest wall, and to show the connection between the lesions. If you have in your mobile, you can send the image, no problem. You can connect it now. Just connect this image from your mobile.
Can you see my screen now?
Yes.
يلا دقيقة، أنا لأنه متأكدة حطيت الصور. Okay. Just give me a second. شايفين my screen صح؟ كده شايفين my screen?
Yes, this is the area of, this is the area of architectural distortion, okay? Go down, and that is a mass. Here, this is a mass, okay? This is a mass within the area of architectural distortion. Go down, yes. Can you see here? This is the intramammary lymph node going all this is a tumor bands or tubular structure filled by tumor band going to the mass within the architectural distortion more medially. Can you make it larger?
I can do it.
Yes. Is it clear here, Dr. Aida? Can you see?
Yes, it's very clear.
Yeah. This is the afferent vessels, okay, taking the malignancy from the mass to intramammary lymph node here. And here down, can you see the mass? Okay, and this is the muscle, okay, the chest wall. Can you see the track infiltrating here and here? Can you see it?
Yes.
Infiltrating, this is the rib, this is intercostal muscle, now is infiltrated by the mass itself. So now you can see it. It's okay. So it became a locally invasive cancer. Okay, thank you very much. Well done. And here you can see this is the mass from one view, and that is the architectural distortion. And also we can use the comparison when the findings are subtle. Just compare the same region in the contralateral breast. Okay. Okay. Thank you.
Thank you.
Well done.
Thank you. Thank you very much. Thank you, Dr. Amna. Thank you, Dr. Rabab. That was a very interesting case indeed. We're going to take questions about the case. Any questions?
السلام عليكم. السلام عليكم.
عليكم السلام.
دكتور رباب، السلام عليكم.
وعليكم السلام. أهلا بروف. مرحبا. الله يديك الصحة والعافية.
تحية عبركم لكل الحاضرين ودكتور عايدة وكل الصامتين والمتفرجين. حقيقة يعني دي كانت أطروحة كاملة. This was not a lecture or 2 lectures or 3 lectures. I think this is heavier than any master degree that's being placed anywhere. وده يعني ما شاء الله ما شاء الله، ربنا يوفقك دائما. هذه مائدة مترعة يعني، في غزارة في التجربة ورحابة في العلم. أتوقف في هذا الحد، وإن شاء الله تواصلي لنفس الحماس والغيرة، وينتقل لغيرك. ويبدو أنه العدوى انتقلت إلى الجيل الجديد. ودكتورة آمنة، استمعت البرزنتيشن أيضا لدكتورة آمنة، وهي في شمال غرب بريطانيا. I better speak to her in English. Maybe her friends are listening at the time. Amna this is a very reassuring incident when we see the young coming forwards, and we have the example of Amna and her presentation now. I'm not talking about anything which is abstract.
Yes.
She is so meticulous with her presentation. She's so
agree.
meticulous.
Yeah,
And
agree.
her structuring is impeccable. I really feel so much reassured that the practice is now going to be taken from us into safe hands, into more able, more ambitious, immaculately practicing a new generation. Congratulations to Amna, congratulations to you, congratulations to the society, to ECHO, and to the presentation. Thank you very much. I don't want to take much time. I could have carried on
شكرا يا
speaking till the
بروف.
morning.
نحن سعيدين أول حاجة وشرفتنا وسعيدين بوجودك معانا، وده شرف كبير جدا 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 بالنسبة لنا يعني. ويور كومنت ده بالنسبة لنا شهادة يعني نعتز فيها.
بارك الله فيك.
الله يبارك فيك.
بارك الله فيك. Well done, Amna.
Thank you, Prof. منك نتعلم.
Thank you.
لا بجد you have done a good job. I was impressed by your presentation.
Thank you. معلوماتك.
لا العفو أبدا. Your presentation, the way of presentation as the prof said يعني it was really an excellent one. The only thing are the missing of the images, and it was technical. It was due to technical problem.
The most interesting picture.
No problem. At the end you can bring that pictures. Okay.
Thank you very much. Any other comments? Any questions? Okay, now we can take questions about the last lecture Dr. Rabab presented. If anyone has a question in that lecture. Okay, no questions. Okay, thank you
said
very much.
You said in the chat there were questions.
Okay.
Before
معك دكتورة نادية. I wanted to ask, and I actually wrote it in the chat. I was interested in these DCIS cases. You said you saw a lot of them. Was this in Sudan or in the time before you were in Sudan?
No, regarding this DCIS and benign type of cares, outside.
Yeah. Outside, yes. Because
I'm talking about my experience outside. Yeah. Because my experience outside, it was the bulk.
Yes, it was most of the time. Yeah,
most of the time, yes. The bulk of my experience, it was outside Sudan.
Exactly.
But the cases I have seen during that short period in Sudan, I feel that is almost equal to the whole period, period.
It was a lot of work.
A lot of work. Yeah, a lot of.
And no time to actually start working on them, to research them, to use the data.
Yeah, a lot of. Yeah,
a lot of data.
We are going to discuss it, inshallah. We are going to discuss
inshallah,
it.
Inshallah.
The MDT meeting. Yeah.
Yeah, and so another positive thing is hearing the voice of Prof. Greetings to you.
No, شهادة كبيرة طبعا. لا يعني زي ما بقولوا، لما الواحد حس إنه راسه كبر وكده يعني. صدقتك صدقتك.
No, for me it was more very lovely memories.
دايما بيشجعونا والله، الله يكرمهم ويديهم الصحة
الحمد لله
والعافية.
الحمد لله.
تشجيعهم ده بالمناسبة هو بالنسبة لنا motivation.
طبعا طبعا كيف. Okay, hopefully we have a good time again together in that country.
أي
يلا إن
hope
شاء
so.
الله. يلا
يلا نشوفكم بكرة إن شاء الله. Still
لازم.
we have lectures tomorrow. Okay. If you have nothing, يعني you can conclude it, Ilaf.
Okay, actually, I don't really want to conclude. It's an amazing symposium. We don't really want it to end. It was very, very enjoyable, very interesting, and I really like the collaboration. I'm sure all of you guys, you did enjoy your time. So thank you very much. We've reached the end of our first day of the symposium. I would like to thank all the speakers, all the organizers, all the moderators, the facilitators, everyone who participated in this. And I would like to thank all the audience as well for the wonderful participation and for your time. And please, we need more people to join tomorrow. We have very interesting topics to talk about. I really hope to see more participants tomorrow. Thank you very much for being here.
Thank you, Ilaf.
Thank you for everyone.
Thank you, Professor.
Thank you, Dr. Abab.
Bye-bye.
Any of the facilitators want to add anything? Amna, Ayan, if you want to say anything.
Amna, where are you? Are you there, Amna?
Can you hear me?
Hello, everyone. Thank you so
Hello.
much for the session and the symposium. It was rich and informative. I'm sure everyone enjoyed their time here. And I hope to see you all in the coming symposium. I'm excited already for the next day. And thank you all for the amazing session.
Thank you for your presentation. Very يعني excellent presentation, Amna.
Thank you,
And I
Dr.
hope
Bob.
we'll share more إن شاء الله.
أكيد إن شاء الله.
إن شاء الله.
Okay, thank you very much. Okay, see you all tomorrow.
Stop the recording now.
Yeah, we're gonna start early tomorrow. It's 10:30.